Thank you for asking me to talk today about my experience with non-invasive fixation in my hernia practice. These are my disclosures. This is the device I've been using for the last 5 years, the Lapro device, cyanoacrylate glue gun from Advanced Medical Solutions called Liquid-Band Fixate. We've also been using the open device of the last year. So why use glue for fixation of the mesh? Because of the complications that can occur with penetrative fixation devices such as tackers and even sutures. We can get stapalgia, staple pain, which can produce chronic pain as well as acute pain, nerve injuries, injury to vascular structures and bleeding from muscle. When the bowel adheres to exposed tacks, this can produce problems as well. And if the mesh is not fixed adequately, it will migrate and cause recurrence. A no-go area for tacking fixation is the diaphragm, which can produce significant cardiac tamponade and mortality. The hernia surge group in their guideline from 2018 looked at the evidence base for fixation in opening world hernia surgery and looking at chronic pain rates. And this was significantly higher for suture fixation and fixation with self-fixing meshes compared to cyanoacrylate glue and fibrin glues. There were also lower acute pain scores for glue fixation and no significant difference in recurrence rates. Similarly, looking at laparoscopic evidence for glue fixation versus staple fixation, there were no significant differences in hernia recurrence rates, but there was significantly less acute postoperative pain in the glue fixation group, and to a certain extent chronic pain was again reduced in the glue fixation. Some of the tacking devices can penetrate the tissues quite deeply, especially a secure strap with 6.7 millimeter penetration. And I myself have had very similar complications when exposed pro-tacks adhered to the colon and to the small bowel and have had fistulas related to this fixation device. This is a patient of mine who I carried out a bilateral tap repair for inguinal disruption 12 years ago. 9 years later, she developed severe chronic pain. And you can see here the pro-tack staples and very close to the bladder as well, which caused some microscopic hematuria, bladder symptoms. And it wasn't until I actually took these staples out laparoscopically that the patient's symptoms of chronic pain and bladder irritation resolved. So can we fix mesh in a better way to prevent these complications, but also to prevent hernia recurrence? And certainly the hernia surge group in their guidelines suggest that we should be fixing mesh in large medial defects and combined hernias during tap and TEP repair, and to use cyanoacrylates or fibrin glue fixation, atraumatic fixation, to minimize the risk of acute postoperative pain. Glue has been around for nearly 20 years now. Fibrin glue has been found to be safe and effective in tap repairs to fix mesh, but unfortunately with fibrin it cannot close the peritoneum. One still has to suture the peritoneum closed. The early glue devices were very difficult to use, imprecise, cumbersome, and the development of better devices later in 2014. Liquid-Band Fixate is one of those devices. It's a cyanoacrylate glue with a very short setting time, a rigid system, a gun system with a trigger action, firing 44 shots, and very simple to prime. Its fixation strength is superior to tacking devices such as secure strap and absorber tack. And we've been using this Lapro device over the last 5 years and found it easy to use with minimal adaptation of technique and minimal issues with device clogging. It seems to be very good for perineal closure as well as mesh fixation. And one of the striking things we saw initially was that patients had very little postoperative pain and very minimal analgesic requirements. So this is a tap repair. This is a polyester mesh. You can see the device. We're firing the device to fix the upper border as we would in a tacking technique. Firing it as a gun. But we're now going onto the pubis here, fixing down onto the pubic bone, which is again a no-go area for tacks or sutures which produce staple pain. We're now over the vessels, the inferior-epigastric vessels, over the floor of the dissection, which again is a no-go area for tacking devices. Here we're closing the peritoneum. We've dropped the working pressure down to 8 millimeters of mercury and fixed the central portion of the peritoneum. And then we can fix laterally and medially. A simple spot or two of the glue and then spreading as a little line of glue seals the peritoneum with a glue closure. And this is a more complete physiologic closure compared to that of a tack or even a suture. So here, just finishing up the peritoneal closure, and we've got a good seal of the peritoneum. The mesh fixation now with the glue, we can actually extend into areas which we could not fix with tackers or staples or sutures. Over the floor, over the pubis, ligament, epigastrix, we can encircle the defect. So potentially a better fixation, which may reduce the risk of hernia mesh slippage and recurrence. This is a large M3 medial defect, a left inguinal hernia. We've done the dissection, and this is just to show how we can extend that fixation. The polyester mesh is in place. So we're now doing fixation of the upper border as we would with a suture or a tacking technique. We're now going down to the pubic bone, fixing at several points on the pubic bone, over the peritoneal ligament here, and over the floor of the iliac vessels, of the inferior-epigastric vessels, laterally over the floor. And again, these are no-go areas for penetrative fixation devices. We can now encircle that defect to fix around the defect to give this extended fixation, and hopefully that will reflect a lower recurrence rate. We reported our early experience 2 years ago in hernia. Our first 200 patients, 247 tap repairs, quite a few bilateral repairs, predominantly inguinal repairs, and we had a low rate of adverse events, very few seromas, only 1 groin hernia recurrence, and very low rates of chronic pain. And that was at a median follow-up of 29 months. Our positive experience with tap repairs and this cyanoacrylate device, liquid-bound fixate, we've now done over 500 tap repairs in the last 5 years with the device. It's a short learning curve, approximately 20 cases, and we've completely abandoned the use of tackers or sutures for tap repairs. And we've now used it in over 200 laparoscopic IPOM repairs to fix mesh. We reported our experience with the IPOM technique in 2020 with a combination of various meshes, including biomeshes. with a median follow-up of 32 months, and again, a low rate of adverse events, low rates of seromas, low rates of hernia recurrence, and low rates of chronic pain. We have been now using the open fixate device, sinoacrylate glue fixation device, for the last year in our open inguinal hernia surgery. This is a slightly different device, but it's still a gun firing shots of sinoacrylate glue. We've gone over entirely to fix our meshes in open inguinal hernia surgery with this sinoacrylate, on the basis of the fact that we can try and reduce the rates of chronic pain associated with our previous suture fixation or self-fixing mesh fixation. And it's a very easy device to use to fix the mesh. We've now used it in over 50 open inguinal hernia surgery cases. Very positive experience. We don't have to be concerned about where the ilioinguinal or iliohypogastric nerves are to avoid injury to those. And very simple to fix, even along the inguinal ligament. It does reduce operating time and potentially reduces those risks of nerve injury and chronic pain. So in our TAP repairs, this non-penetrative fixation device has potentially better fixation in terms of surface area, extended fixation, and potential to reduce these penetrative complications. In our open devices, again, reducing the rates of chronic pain. We've now used it in all our open abdominal wall reconstructions and our retrorectus mesh fixation techniques. So for glue fixation in hernia surgery, we can reduce penetrative complications, especially nerve injury and chronic pain, as well as bleeding complications, and a potential to improve patient outcomes in terms of reducing hernia recurrence. Thank you.